Hello, this is Dr. Bernstein with our November 2019 teleseminar. Before we start, I want to give you the usual caveats. The answers I give are generic answers. I cannot know a given questioner inside out. I don't know. I haven't done a physical exam on him or her. I haven't gotten a complete history. And my answer is given for the general audience, so just to educate you in general. It may not really pertain to this individual. One other warning, we get many questions that are a page long. If I were to read a page to you, you'd switch me off. It would take me about 5 minutes just to read the question. So when I get such a long question, I don't answer it. I just scrap it. Likewise, if an individual asks several questions at the same time, I'm only going to answer one of them. So be careful to keep your questions very abbreviated so that they won't be automatically screened out. Before we get started, we have a couple of special subjects that came up in a recent issue of Diabetes Care, published by the American Diabetes Association. One dealt with a class of drugs called Dpp-4 Antagonists. They're also called gliptins, and some of the names of the drugs are sitagliptin, saxagliptin, vildagliptin, and I have not used this. I've deliberately not used this class of drugs for any of my patients because when I first started to use them, I found that they had almost no effect on blood sugar, very small effect on blood sugar, and did not curb appetite or overeating as the GLP-1 agonists did. So there was no purpose in them. However, they're widely used, and they work by destroying the enzyme that destroys GLP-1. The body naturally makes GLP-1 while eating, and GLP-1 has many benefits, including increasing satiety, making you satisfied with your meal. However, the body also makes an enzyme, dipeptyl peptidase number 4, DPP-4, that destroys GLP-1. And the gliptins destroy the destroyer. Anyway, it's now reported that there's a 24% increase in pancreatitis in the people who take the gliptins, and an 81% increase in pancreatic cancer. Now, pancreatic cancer is pretty rare, but nevertheless, this increase exists after only 6 months on a gliptin. They also found that by waiting longer, maybe a year or two, the percentage of increase did not increase. So there are hazards. It's of a low level on the cancer, but I found that GLP-1 agonists actually caused pancreatitis in several of my patients, and I may have only had, let's say, 50 patients on the GLP-1s. That would have meant something like 6% of my patients were getting pancreatitis. So I think the incidence of pancreatitis from both classes of drugs, the DPP-4 antagonists and the GLP-1 agonists, is much more than has been reported. Another article in the journal Diabetes Care recently gave a 10-year update on the Edmonton protocol. This is a protocol for supposedly curing diabetes that is performed at the University of Alberta in Edmonton, Canada. They transplant beta cells from the pancreases of cadavers to humans, human diabetics, and the beta cells remain functioning due to immunosuppression of the recipients. Now, in my experience, immunosuppression is worse than diabetes, much worse. It exposes you to infections that are not fought off by the immune system, and also to malignancies, a wide range of malignancies. Now, why do I feel strongly about this? Because I've had an immunosuppressing disease, CVID, since childhood, probably since I was born. And I already have developed throughout my life many severe infections. I had severe disabling sinusitis, C. difficile infection of the intestines, which often is fatal. I've had treatments for the immunosuppression that caused glaucoma and rendered me almost blind. I have a long list of problems associated with immunosuppression. I don't have any long-term problems associated with my diabetes because in 1970 or thereabouts, I managed to normalize my blood sugars. So it's much more efficacious to learn to normalize your blood sugars than it is to endure immunosuppression. And these patients were put on very potent immunosuppressants. The long article on the update gave all kinds of details and very briefly mentioned some of the outcomes, including, I believe, several cancers, a number of infections, etc. There were several amputations and other elements that could be associated with diabetes. And the question, of course, arises, was it due to the diabetes that preceded the islet cell transplants, or was it because the blood sugars after the islet cell transplants were not that great? Now, their target A1C was, I believe, 6.9. No, I think 6.5, which would have been an average blood sugar of 160, which is about double normal. What they actually achieved was a range of A1C values from 6.1, which would be about 144 milligrams per deciliter average, to 8.0, which would be an average of 220 milligrams per deciliter. So these people throughout the study did not have normal blood sugars and could have developed diabetic complications. So it could be that the increase in kidney disease and amputations during the study were brought about by the higher blood sugars during the study, or they could have been brought about by the higher blood sugars that preceded the study. But all in all, it seems to me that it's much wiser to teach patients how to normalize their blood sugars than it is to put them on potent immunosuppressants. Now we'll get to our questions. I have a neuroendocrine tumor on the tail of my pancreas, measuring 7 millimeters. It's been stable for a year since it was discovered. Recently, my diabetes has gotten worse. Could this be connected? If I need surgery on my pancreas, will my diabetes turn into type 1? So this must be a type 2 patient. Well, it all depends on how much of the pancreas they have to remove in order to get all of the 7 millimeter tumor. Now the pancreas is pretty small, but 7 millimeters is a relatively small part of it. So I can't really answer your question. You can ask the surgeon what his experience is, or you can consult a specialist in neuroendocrine tumors. This is a very narrow specialization. It's hard to find people who specialize in it. It's interesting that when I was in medical school, the chairman of our Department of Medicine was a specialist in neuroendocrine tumors, so they do exist. After 35 years of roller coaster blood sugars and high A1C, I found Dr. Bernstein's book. This was too late to prevent heart disease, and on June 11th of this year, I had quintuple coronary bypass surgeries. My cardiologists are telling me to eat low saturated fat to protect the new vessels. I have attempted, but again, my blood sugars cannot be controlled eating so much carbohydrate. After 3 months, I have again returned to Dr. Bernstein's plan, and my blood sugars are in the 80s. Is low A1C more important than low saturated fat to keep these vessels clear? Well, if you've watched my videos, you've heard me repeatedly talk about the cholesterol myth or the fat myth, which was debunked many years ago. The cause of, if you had to focus on one food that causes heart disease, it's carbohydrate and elevated blood sugars. The fats are benign. Now, you could have a low carbohydrate diet that's not loaded in fat. And by the way, this distinction between saturated fats and unsaturated fats does not seem to relate very strongly to heart disease. I have been on a low carbohydrate diet since 1970, and I run up the stairs, I exercise at above my theoretical maximum heart rate. I think my theoretical maximum is 158 beats per minute at my current age, and I exercise at 160. This is a myth, and you should control your sugars because elevated blood sugars are strongly associated with heart disease. Are you accepting new patients? I feel hopeless by every other doctor. I need serious help as a type 1 diabetic. Yes, I'm accepting new patients, but the reason I wrote my book is because I can't handle every diabetic in the world, or every diabetic who can read, and many people cannot travel great distances to come to see me. So I would suggest that you read my book, Diabetes Solution, get a friendly, kindly family care physician who will prescribe the things that you find you need. And as the prior questioner says, you'll be able to achieve normal blood sugars. Can incretin mimetics help with emotional overeating? Could I inject a short-acting type when I feel like binging? Well, it's very interesting because that's just what I do with my patients. I use the incretin mimetics to cause satiety. They also slow stomach emptying. So I can see that this person did not read my book, Diabetes Solution, because we actually tell you how to use them. And I specifically try to use the short-acting ones before a meal to make them work for that particular meal that you might be overeating. Or if you're overeating after the meal, I time it to start working after you finish the meal. Can wine or other alcohol cause dramatic, unpredictable drops 12 to 15 hours later? Well, if you happen to take it while you're eating or digesting a meal, and you already have gastroparesis so that your meal digests very slowly, the wine can paralyze the pancreas so that you cannot convert the protein from the meal into glucose. And if you're a type 1 diabetic or even a type 2 who takes insulin to cover meals, your blood sugar can go too low. This is explained in my book, and it's been explained on prior videos. So taking too much alcohol with a meal can cause low blood sugars later on. That's why the safest time to drink alcohol, if you must, is well between meals rather than at mealtime, as the ADA recommends. Can you please explain the mechanisms of how hyperinsulinemia causes harm to the body? Well, hyperinsulinemia can come about several ways. One way is to inject insulin that you don't need, as the ADA frequently recommends. They like to give high doses of basal insulin that force people to eat all day long to cover the insulin. That's very common, and the harm it does is, one, it can cause hypoglycemia if you don't keep covering it with food all day, and two, it makes you fat. Another source of hyperinsulinemia could be a tumor and other endocrine abnormality, and that likewise can cause hypoglycemia, blood sugars that are too low, and then forces you to eat because you get hungry, and that makes you fat. So the main end result would be fat building. But there's also the hazard of going too low from hypoglycemia, and you could become unconscious or worse. Is powdered sweet leaf stevia an acceptable sweetener? Again, it's covered in the book, and you have to watch out that you're using a brand that does not have added sweeteners like sorbitol or other sugar alcohols. Recently, one cardiologist suggested I take vitamin K2. Please let me know if vitamin K2 could help save my heart. Well, you could look it up on the internet as well as I could. I took a look, and some studies say that it lowers the infiltration of soft tissue by calcium, but this may be an advantage. If you have plaque in your coronary arteries and the plaque is infiltrated with calcium, it becomes stabilized and is less likely to break off and block an artery out upstream. So there's a possibility that it may be of some value. I haven't seen any scientific articles indicating that it's of great value. So I'm pretty much uncertain about this. Do ketone bodies cross the placenta in type 1 diabetic mothers following a low-carb diet? What effect do the extra ketones in the blood have on the baby? Well, when I talk about ketones, I frequently mention that any pregnant woman will have ketones in her urine frequently, certainly upon arising in the morning when she's fasting. And this is because during the first trimester, she builds up fat to provide energy for later in the pregnancy. And later in the pregnancy, when she is usually unable to consume the large amount of food that it takes to support a baby that's now bigger than it was at the beginning, she starts metabolizing the stored fat. And both the baby and the mother make ketones. It's part of a normal pregnancy. So I don't think that you have to worry about ketones during pregnancy. Ketoacidosis with very high blood sugars and dehydration, of course, is very dangerous, but that's not caused by a low carbohydrate diet. Do you have experience with or do you have an opinion on the widely advertised Trulicity medication? Trulicity is a GLP-1 agonist, and it's long-acting so that you can supposedly take it once a week. Once a week is just the opposite of what I seek in a GLP-1 agonist. These are agents that slow stomach emptying and cause satiety so that you're less likely to overeat. And they're of special value for people who are overeaters. But if you're going to be stimulating the receptors for GLP-1 all day long, all night long for a week, you're going to down-regulate the receptors so that you will not get the benefit of satiety. And I've tried it with patients, and indeed, there's no effect. So it defeats the whole purpose, what to me is the major purpose of the GLP-1 agonists. Please advise if Basaglar has the same or similar affinity for IGF-1 receptors as Lantus. Basaglar is another name for Lantus. It's another brand for glargine, which is Lantus. So the cancer risk is the same. I use 4 injections a day. As a female, I worry for the hormonal effects of your low-carb diet and to what the future brings. Do you have any words of wisdom from tales with other patients? Well, if you look at pages 3 to 31, that's 28 sequential pages in my book, you'll see comments on how this diet has helped 13 of my patients. So that's one source of listening or reading what people say about the benefits they've incurred. Another source is to take a look at type 1 type ONE grit on the internet, where people are comparing results, and you'll see that their lives are changed dramatically, and certainly their hormone functions, if anything, would improve. Granddaughter, 7 years old, diagnosed 2 years ago with type 1. She recently got sick and vomited a few times. For the next 3 nights, her blood sugar was near 300 and more vomiting. Endo has advised 4 units Lantus given at bedtime around 9 p.m. She is running noticeably lower. She has complained just yesterday of burning when urinating. The mother asks, is this connected? My best guess, and it's purely a guess, is that she had high blood sugars during this period of time, and that makes you especially susceptible to urinary tract infections. So it could well be that she had a urinary tract infection. Now, with adults, it's usually advised that if you have a urinary tract infection, but it's asymptomatic, you don't necessarily have to treat it with antibiotics. You could, for the time being, ignore it. So what one would do with a child, I don't know, because I haven't seen studies of urinary tract infections on children. But that's one possibility. It's the only one I could think of. And I certainly would want your endo to teach you how to handle vomiting episodes. We have a whole chapter on it in my book. We use substances to stop the nausea and vomiting. We use special solutions for rehydrating. We have a whole protocol for how to normalize the blood sugars, etc. I'm 39 years old and pregnant with my 3rd son. For all 3 pregnancies, I've had gestational diabetes. My A1C post-pregnancy after my first child was 6.0. Now, 4 years later, my A1C is 6.3, taken while 12 weeks pregnant. Should I be treating myself as if I'm already diabetic? Well, 6.3 is an average blood sugar of 152, and I don't think that that is very good for the fetus. I think that most pregnant women, non-diabetics, have blood sugars in the 60s. So certainly you should normalize your blood sugars. Very important. And that means treating yourself as if you have diabetes. I would call it diabetes. I don't know what your endocrinologist would call it. I might add that I've seen disasters from happening to women whose obstetricians told them that A1Cs in the sixes were normal, and the fetuses suffered therefrom. I know, let's see. I eat low carb, some whole wheat peas, some whole wheat pasta, chickpea products, buckwheat for pancakes, and waffles. I know I should eat one, but I eat 2 waffles. A light English muffin with egg and bacon shot my blood sugar up. Are my portions too much? How do I lower blood sugar without feeling so hungry? Well, the first thing you should do is cut the carbohydrate. You say you're on a low carbohydrate diet, but you're eating more carbohydrate for breakfast than I eat in 2 days. So I think you should start cutting way back on the carbohydrate, and that you read my book, Diabetes Solution, and you may need some appetite suppressing treatment, possibly GLP-1 agonists to curb the craving. My question is regarding your patent using the replication of white blood cells to cure diabetes. Please elaborate, if you can, on any progress to date regarding this method of curing diabetes. Well, first of all, we ran out of money and had to stop the application. And it was not a cure. It was a way of trying to find out how the immune system is different in people who develop diabetes from people who don't develop diabetes. And it involved using a flow cytometer to compare thousands of cell types in people with recent onset diabetics versus people with no family history of diabetes and no personal diabetes. Several investigators have looked at a few cell types where they arbitrarily, I shouldn't say arbitrarily, where they make a guess at what immune cells will be abnormal in the diabetics, and then they test for those. But my idea was to test all of the cells in the blood, all of the white blood cells, and see where the differences were. As it turns out, other studies which have looked at more white blood cells, probably not all of them, have found that genetically diabetes is a multifactorial disease with some diabetics having only one known genetic abnormality and some having many known genetic abnormalities. But my technique would have been a thorough way of finding out what are the major differences. My last A1C was 5.3%. What would you suggest? Well, it's a good question, because the ADA would say that your A1C is well within the normal range, but it's an average blood sugar of about 112. And when non-diabetics go on low-carb diets, they end up with A1Cs between 4.2 and 4.6. So I would first of all see what happens if you lower your carbohydrate intake. Then you could check your A1C and see where it is. If you get it down to 4.2, you're certainly not diabetic. And even if you're 4.6, you may not be, but it's sort of uncertain. I would say 5.3 is sort of a borderline thing. I would treat it, but most endocrinologists would not. They'd call it normal. I've studied your book and didn't find an answer for what I'm experiencing. I'm controlling my type 2 diabetes with intermittent fasting and low-carb, high-fat diet. My basal insulin is 2. Is this basal insulin pathologic? Does that mean I'm not producing enough? Well, I know of no labs, no major labs in the USA that measure basal insulin. The closest to that is a measure of C-peptide, which is in certain ways is equivalent to basal insulin. However, basal insulin levels depend upon what your blood sugar is at the time. So if you have a blood sugar of 200 and you're not diabetic, you should have super high levels of basal insulin. And if you have a blood sugar of 70 and you're not diabetic, you should have 0 basal insulin, because additional insulin would lower you further, and you're already too low if you're not pregnant. That's basically it. I also might point out that I seriously question your use of a high-fat diet. Most people on high-fat diets don't get enough protein. They're focusing on fat instead of protein and are frequently protein malnourished. We've seen some people who were in pretty sad shape by trying this high-fat, low-protein diet, which is very unwise. Also, I question the intermittent fasting, whether it really makes a difference. Some people have claimed that it does. I've known a number of people who do it and don't lose any weight. So I don't know whether that's of any value at all. I'm wondering if there's evidence that glycogenolysis stops working properly in people with type 1 diabetes. It actually tends to work too much in people who don't have adequate insulin levels. Glycogenolysis is the conversion of stored glycogen back into glucose. Glycogen stored in the liver and in the muscles. And diabetics, without eating anything, can have their blood sugars increase by glycogenolysis, converting the stored glycogen back to glucose. The one way that glycogenolysis stops working is if you consume too much alcohol, especially at mealtime when you're eating protein. The alcohol paralyzes the liver, cannot convert the stored glycogen back to glucose. Is there any link between osteoporosis and type 1 diabetes? I've had type 1 for 35 years and was recently diagnosed with osteoporosis. I'm a 55-year-old male. Indeed, there is. In fact, When I was, I guess, about 20, and my blood sugars had been poorly controlled since the onset of my diabetes at age 12, I had to have an x-ray of an injury to a finger. And the radiologist had mentioned on the report very low bone density in the wrist. And years after I got my blood sugars controlled, I needed an x-ray of a hand for another injury, and asked the radiologist to comment on the bone density, and it was absolutely normal. So, and there's plenty of literature indicating that high blood sugars are associated with diminished bone density. So it can cause osteoporosis. I'm a type 1 diabetic. Why do I need to take long-acting insulin? It makes me gain weight and puts me on a cycle of increasing insulin. Can I completely avoid it? Well, first of all, I would say that you should read my book, Diabetes Solution. And secondly, most diabetics who come to me for the first time, type 1 diabetics, are getting excessively high doses of long-acting insulin. Not only that, when I see in the literature a report of an efficacy study on a new long-acting insulin, they inevitably give greater than proper basal doses in order to make the insulin last longer, because they want to claim that one shot lasts 24 hours. And if you give a big enough dose injected in one place under the skin, it'll take a long time to be fully absorbed. So it's a sleazy way of making the long-acting insulin last longer. So the manufacturer gets approved based upon certain dosing, and the package insert will probably recommend certain dosing, and it'll be too much, and it'll force you to overeat, and you'll get too fat. And that's probably what's happening in your case. You're getting more than a basal dose. Very common. In fact, as I see it, it's much more common than not. Most of the people getting long-acting insulin, at least in the USA, are getting too much. How can I be diagnosed as a type 2 diabetic when my doctor and lipid specialist keep telling me my fasting glucose 107 is in normal range, as is my A1C of 4.9 to 5.3. Well, if you're already on a low carbohydrate diet, I would say that you're probably diabetic. But if you're not following a low carbohydrate diet and you have an A1C as high as 5.3, it's sort of a question mark and should be looked at more carefully. Might want to check your blood sugar after meals and so on. Take a look at my book, Diabetes Solution. How do I maintain adequate hydration? I have type 2 diabetes and am constantly dehydrated. My doctor recommended 8 to 10 bottles of water per day. but many times I drink much less. Well, let's see how much is 8 to 10 bottles. 10 12-ounce bottles would be 120 ounces, which is 4 liters or 4 quarts a day. Now, to require that much fluid, you'd probably have to weigh around 300 pounds. A 150-pound person needs about 2 liters a day. So, but there's one thing that might be going on that you don't mention. Either if you're diabetic and have high blood sugars all the time, you're constantly peeing and losing fluid. And like me, when I had high blood sugars, you'd be constantly thirsty. So that's one possible cause of the constant thirst. Another possible cause would be if you're diabetic and you're taking an SGL2 inhibitor. This is a class of drugs that cause you to pee away excess glucose. So diabetics with elevated blood sugars are forced to pee even more than the average diabetic with a high blood sugar. And there's a high incidence of dehydration in these individuals. In fact, I've had some new patients, new to me that is, who had been put on these SGL2 inhibitors, and their blood tests showed signs of dehydration. They had usually high hematocrits, low sodium from peeing a lot, etc. There might be other endocrine abnormalities that cause thirst, but if you're diabetic, it's probably high blood sugars. How do I split the dose my son takes of long-acting insulin so he can get it twice, 8.5 hours apart? Do I give half the dose in the morning and half dose in the evening, or is it trial and error? He is 4 and just diagnosed. We have had him on the low-carb, high-protein meals, and his blood sugar has been pretty stable without giving any insulin during the day at all. But it's still a little on the high side, 100. He's getting 2.5 units of Lantus at night, which I requested to change to Levemir. Also have diluent solution and vials on their way. Well, first of all, his blood sugars are running 100, and for kids, blood sugars are usually in the 60s and 70s. So it's about a third too high. And you might want to read my book and be more focused on his precise blood sugars. The second thing is that there's no diluting fluid for long-acting insulins anymore. The good insulins, Ultralenti, for example, had diluting fluid. The prior insulin, protamine zinc, had diluting fluid, but those have been abandoned for to make room for newer products that were under patent because the patents had expired. So we have insulins that cannot be diluted. It's a sin to children because we don't have any long-acting insulin that children can safely use. One solution would be to take multiple small doses of diluted NPH. NPH is not a long-acting insulin. It may work for, let's say, 8 hours. So if you had 3 shots a day of diluted NPH, it might cover the basal state. But don't dilute your current long-acting insulin because it won't work well. How does Livongo 1 drop BG meter? How does Livongo 1 drop BG meter compare to the accuracy of the Freestyle Freedom Light? I use the 1 drop and find it very useful. Well, you could look on the internet and see if any people have compared the two. I looked and I found only one person had compared it and found it to be grossly inaccurate. But someone else might, several other people might find it to be accurate. I still recommend the Freestyle Freedom Light because nothing that's come along that I've seen has really compared. There's this one next, which when I tasted was sort of close, but other people have told me that it was way off. And yet still other people have said that it was right on. So that tells me that the batches are different, which is what I found with the One Touch, that there were some good batches and many bad batches. The problem is usually with the strips, not with the instrument. Quality control on strips. Well, thanks for listening again. Our next teleseminar is December 25th, 2019. So I wish you happy holidays. And at this point, I'd certainly like to thank my producer and associate producer, namely R.D. Dykman and his son, Dave Dykman, also known as Bigfoot, who's been on my insulin and low carbohydrate regimen since he was diagnosed with type 1 diabetes 7 years ago. He's grown to be a giant and is a superior athlete in multiple sports and walks around with normal blood sugars. Thank you. Okay.